Thanks very much for inviting us today to speak about the medical and dietetic update on GSD. Dr. Mundy was supposed to speak with us today, but unfortunately she can't be with us today, so Abby and I are doing partly her talk, but the good news is that most of the update is on dietetic, so hopefully you won't miss too much. So I know quite a few of you are familiar with GSD, but those who are not familiar, and I know it's first thing in the morning, but I'm going to do some biochemistry, so hopefully bear with me. But to understand the medical and dietetic update, I can't really do it without doing some biochemistry. So just to run over, GSD is an inherited metabolic disease, and the incidence is about 1 in 20,000. Like all the metabolic diseases, there's an enzyme which is deficient, and which one is deficient gives you the different types of GSD. So I think this pointer might not show it too clearly, but you have GSD1, which if you don't have this enzyme, there's a problem. There's GSD3, which is a debranching enzyme, and then there's 6 and 9, which are up here. And in essence, with GSD, if you, there's a problem breaking down glycogen or releasing glucose. So if that's happening, then you get low blood sugars. And your body tries its best to maintain the glucose. And so it does a lot of counter-regulation hormones come into play, and the body's trying to find a fuel so you can maintain your blood sugars. So as a result, there's a lot of metabolites that get produced, like lactate and ketones, which the body then can use as fuels, the untreated child actually treats themselves by producing these metabolites. But unfortunately, these have a consequence for growth and for cardiomyopathy and GSD3 as well. Now, I think this is going automatically, because I'm not pressing and it's moving on. Let me just go back. So, so you get hypoglycemia, and it can affect the liver and the heart. So the traditional treatment is you just provide continuous glucose as a continuous feed, or you do regular feeds every couple of hours, or you use cornstarch as a slow-release glucose. And honestly, if you did that now, you wouldn't go far wrong. You would still improve the child, the symptoms would go away. But is it actually the best treatment? And we now know that we have to look, it's more than just making sure blood sugars are okay. We know there's long-term consequences of if you're feeding around the clock with glucose, you can get obesity in GSD, and also cardiomyopathy, GSD3. So this is where this talk comes about, really, because we're all working in our little hospitals doing the best we can for our GSD patients. And we hadn't really had a meeting where we bring all the health professionals together to discuss what we're doing, if there's any differences. So the AGSD, which is the Association for GSD, organised a meeting in May and then a follow-on meeting in October, where they brought the health professionals from the different hospitals together, and also some of the parent speakers as well, who are from the GSD1 and 3, who wanted to pose questions where they felt there was a discrepancy between maybe the States and our treatment here in the UK. So we came together, and then, like all meetings, everyone gets a little job to do. So we all went away and we had various jobs to do, and then we met back again and to report back on it. So I'm just going to report firstly on the medical update from that. So osteopenia is known to occur in GSD. So the first area that they're looking at, and this is coordinated by Great Ormond Street, is look at bone health. So they're looking at the longitudinal study of DEXA scans, and so what's going to happen is they're going to try and collate various data of bone age, height, weight, calcium, vitamin D, and looking at what is happening with the DEXA scans there. With the pre-albumin, we're looking at that because we're thinking that may be a marker for protein synthesis. So we're working with Birmingham to look at that. on the ketotic, ketotic GSDs. And then during the meeting, discussing the various GSDs, it became apparent that some of the Birmingham GSD1 patients seemed to be slightly more severe than we would have, say, in London or in Manchester. So, and we want to know why this is. So they tend to be more severe in the fact that they have more inflammatory bowel disease, and a lot of them are transplanted. So there's somebody looking at that and looking at, is it the genetic pool that's in the Birmingham area? Why are they very different from the rest of the UK's GSD1s, 1Bs? So that was the main, so there's a lot of health doctors out there, but they've only got 3 jobs. So hopefully they can come back with, and I'll be able to give you another update soon on that. But it does involve obviously looking at patient details and stuff, so it could be quite a lot of work to go through, but I think they've got some registrars involved to do that. So that was all from that meeting. The other thing that I wanted, which I presumed everybody wanted to know about as well, is what's happening with Glide. This is a slide from VitaFlow, so I can't really say too much because we're still within the trial. So for those not familiar with Glide, Glide is a trial that we're comparing cornstarch and glycoside, and a number of trials were done a few years ago, but this is the long-term, looking at it for 2 years. So it's a multi-centre trial, international, so we've got the States, Netherlands, France, and then 3 centres in the UK which are participating. And we're at this stage now, which is the interim analysis here. So we started in 2016, we're nearly finished. So hopefully, I can't say any more about the outcome on that, but hopefully we'll have some results and be able to tell you that soon. So if I move on to now, the dietetic update. So I'm going to touch on 3 things, and some of them you might think, oh God, we've been looking at this for such a long time, this is hardly an update. So the first one is fructose and galactose restriction in GSD1. Do we do it? Do we not? Should we? Protein and fat supplementation in GSD3, and then growth in GSD and the obesity rates. So this is where the biochemistry first kicks in, I'm sorry. So the reason why we looked at this is because when we had our meeting, a lot of centres in the States or some European centres restrict fructose and galactose. Generally, the thought is in the UK that we don't. And what we want to do is look at that. So I'm just going to explain a little bit so that you understand why we are considering this subject. So if you just go back, this is GSD1. So if you have an untreated GSD, their blood sugars, they'll be using their blood sugar will fall. But as I said before, their body tries their utmost best to try and maintain that blood sugar. It tries to find any form of fuel to try and keep that blood sugar up. So what happens is that you've got a pile of glucose 6-phosphate that's sitting there and it can't be released to glucose. So it just sits there. And the body wants to use that to use another fuel. So it goes through glycolysis, pyruvate, and the lactate goes up. And that's what the body is using for its fuel. So untreated GSDs, they will come and they'll have high lactates. And they'll be self-treated because they will have lactate, and that's what their brain is using as a fuel. We come along and all we do is we then give them glucose more frequently, and so the body then doesn't. You're giving the blood glucose, and then you're not having to go through this pathway, and the lactate is not as high. So that is treated GSD. The countries that avoid fructose and galactose, because that doesn't go straight into the blood. It would go through this pathway again and increase lactate. So they're saying, well, if you can't use it, why are we giving it? And we're going to cause the lactate to go even higher. So the theory is there. Why we don't generally do that here in the UK is because when you're treated, does the small amount of fructose or galactose, is that going to increase your lactate? Is it going to be detrimental? Sorry. So we don't, I thought we didn't really restrict in this country. So oh, there's a delay. Okay, right, sorry. Once, okay, right, sorry. So in America and some European centres, they restrict. We here in sort of London and the UK, generally, I think everybody is sort of, we're trying to keep the lactates as near as possible. And at night time, a lot of centres would keep the lactates a little bit higher because it can be used as a fuel. But there's no studies comparing this. So when I looked at this a number of years ago now, Saunders, which is a group in America, they everybody was on a fructose and galactose restriction there. And they had a paper and their mean lactates were 2.5. A Brazilian group, Santos, it was a paper actually on obesity rates in GSD, but they also documented their lactate levels in their paper. And their lactates were 2.9. And then I looked at ours using our profiles when they come into hospital and looked at our mean lactates, and ours are 2.5, and obviously we don't restrict fructose or galactose. So in my mind, we're not doing any worse, and we're still, still getting the same lactates. So this was brought up in the meeting, and they said, could I contact the dietitian? There's a dietitian in Denmark who's looking at the restrictions, and could maybe we join in with them, and we could do a multi-centre trial to see, well, to answer this question, if you give a certain amount of fructose, is it going to cause the lactate to increase? But before I did that, I kind of thought, well, I feel that we don't do it in this country, but do we really restrict or not? So I sent out a survey to the BMDG dietitians, and I had 15 replies, thanks very much, to all those that replied. So I've got across 8 paediatric hospitals, 3 that did both, and 4 adult centres. And what the first question I asked is, do you restrict galactose? So majority said no. Those that said yes, some of them said that it was actually standard practice for the infants. So all their infants get put on a soya formula there. Sometimes, and I put my hand up for that one, we've only done it on one patient, and because we had a new GSD, it was 90 minutes. They couldn't go any further than 90 minutes, or they couldn't even get to 90 minutes. We tried to put in all the carbohydrate, and that didn't make any difference at all. And I was very reluctant to change it because I've never had to do it. I felt like you'd always do it with a standard formula. But when we changed to iSoy, 90 minutes we could get it. So I think there may be an argument to say, well, if obviously if in a baby you're using their prime source of carbohydrate is milk, then yes, maybe it is you should maybe be avoiding galactose there. But it's still up in the air at the moment. What about fructose? So to summarise, no one is giving a strict fructose restriction there. Some centres are saying that they say you can have 1 piece of fruit a day, you have to avoid fruit juice. There was no restriction on vegetables. But a few centres commented that, well, the patients are doing it themselves because they've heard from America that that's the treatment, that's the best treatment to do, and they want to do it themselves. So a few patients were actually restricting it themselves there. I'm trying to do gradually, but I'm not. So then I looked at, this is Kathleen Ross, who's the dietitian for Dr. Weinstein, and that's their guidance. So they have quite strict guidance on fructose and how much you're allowed to have. And they have little cards that tell you what each food would have and how much fructose and galactose it has in it. We obviously are not that strict here in the UK. So then I contacted the dietitian from Copenhagen, who is doing a trial. So she's doing a trial on paediatrics and adults, and it's starting next year. It would involve an overnight stay, and what they're going to do, they would do their usual regime overnight and breakfast, and then they would have some milk, which is obviously the galactose, some juice, which would be the fructose, or some water, and then they're going to measure every half an hour the lactates, glucose, and triglycerides. And the aim is to see if you have a certain food, would it increase the lactates? So when we had our meeting, we felt that we would be interested in joining in with a trial like that, but obviously it would be costly because the patients would have to come into hospital overnight. So the next step is to, still waiting for the clarification from the dietitian, but we're looking at maybe to apply for a research grant to, and then a little, if anyone's interested in joining, we could then consider this to go for a multi-centred trial there. But I'm still waiting. She's taken a long time to get her project up and running. I think it's been going for, it's a want for her for a number of years. So it's probably going to start next year, she thinks. So that's on galactose. So the next subject, again, people will say, oh, but we've heard about this for so long. And I was thinking back, and I couldn't get the date, but I know I had a BMG meeting in Edinburgh many, many years ago, early 2000s, and we discussed this subject there. Should we be supplementing protein in GSD3s? And so we're still asking the same question now. The difference being is that there's been a lot more cases being published of the benefits of supplementing with protein, particularly for cardiomyopathy and GSD3. So again, the second bit of biochemistry. So to understand, this is GSD3 now, which you have to think of as completely different to GSD1. So here you have a problem breaking down glycogen. And you've got no problem, once you've got the glucose 6-phosphate, releasing it. Okay, you just got a problem breaking down your glycogen, okay? And what happens is it gets broken down and it forms a very unusual structure, which, for want of a better word, it can be kind of an irritant to the heart, and that's why you get cardiomyopathy. It's called limit dextrin. One of the things that is different from GSD1 is that gluconeogenesis is still functional. So you can still get some fuel from protein, and you can get some fuel from fats, okay? So the body can use those two to ensure that the glucose is maintained. The reason why it affects your muscle is because if you want to get your fuel, so you're going to break down your muscle because you want to use that protein, you then get muscle aches, which is what the patients describe, and your CK goes up. And as I said before, this unusual structure, the limit dextrin, can form in the heart, and it can give the cardiomyopathy. So what is the best treatment? So you could do round-the-clock glucose, and you could match it up very carefully with your energy requirements, etc. But you're never going to get it perfect. You're always either going to give too much, and then you're going to store all the glycogen and not be able to use it, or you're going to give too little, and then you have to break down your muscle. So we can't get it perfect. So that obviously would be the perfect thing, is just to provide exactly what you need, but we can't do that. So then the next thing is, well, can we use a different fuel that GSD can use? So we've got protein and we've got fats. And in essence, they just provide energy. There's nothing special about them. They just provide the energy which the body would then use rather than breaking it down. So is there any evidence for this? So there are lots of cases out there that show either, if you supplement with high protein or if you supplement with fat, we do kind of ketogenic, it all improves the cardiomyopathy. So this is a summary of lots of the papers. So here it's protein, fat, and carbohydrate, and I just want to show you that it's varied. So they're all primarily single case studies. So the patients have all got cardiomyopathy, and they need to do something quite drastic because they're either on a transplant list or they're dying. So they need to do something, and so that's why some of them are quite dramatic in their approach. So what they've done, they're all done something different, and then what they've tried to say at the end is what is responsible for improving the cardiomyopathy. So this group, the American group here, said that they increased the protein to 30%, and it decreased the CK and increased the cardiomyopathy, and they said it was because of high protein. This group, they didn't increase it so much, but they increased the fat, and decrease the carbohydrate. Here, this is a combination of fat and carbohydrate there. They thought it was more to do with if you limit the carbohydrate, then there's not much of an insulin release there, so that's the benefit. This is an older patient in the Netherlands, and they had a huge amount of protein. 43% of the diet was protein there. And then the last couple here are slightly less in protein. So what is it? Is it fat? Is it protein? And what I think is common to all of them is, obviously if you're increasing protein and fat, in theory, if you're making the same giving the same calories, you are just reducing carbohydrate. So is that in essence all it is? So whatever fuel you're using, if you just reduce the carbohydrate, you then reduce the limit dextrin, and that's actually what's improving the cardiomyopathy. But there's no long-term data on cardiomyopathy either. And it's difficult to measure it. And then when you have to look back, because we've tried to look at it ourselves, but at the time when we weren't really looking at protein, it's very difficult then to work out the protein from the diet and the prescriptive protein and to actually see if we did this, did it do anything different? So at the moment, we don't have any studies on that. So if we look at it, well, protein may be easier to supplement. Why is it beneficial? So if you give protein, you can use that as an alternative fuel. It may improve protein synthesis if you're giving more protein. And like I said before, if you increase the protein, in theory, you should decrease the carbohydrate if you don't want to overdo the carbohydrate, the calories, and then you're going to decrease the dextrin. So what we were doing was that we would kind of be reactive. So if the CK levels were about over 1,000, we'd then do something about it. We would then increase some protein and then we'd see a drop. And we do this with protein foods and supplements. But now we've realised that we should probably be doing it with all our new patients. So all our patients now get put on a high protein diet from diagnosis onwards there. But what I wanted to see was, again, in the meeting, we had a raise of hands, who's supplementing with protein, who's supplementing with fat, and hands were put up and varied what were you supplementing with various proteins. But obviously that was not reflective of the rest of the country. So I then did a similar questionnaire and asked people, for those who've got GSD patients, and obviously the no comment bit is the dietitians that responded, but they don't have any patients. Do you supplement with protein? So about 5 centres said yes, quite a lot said no, and then the responses for sometimes was, well, yes, if they had high CKs or cardiomyopathy. Do you supplement with fat? So majority said no. The centres that have done, I know Fiona has done in Manchester, and that was for cardiomyopathy there, and it was more of a modified Atkins ketogenic diet there. But generally, I think people are probably supplementing more with protein. Then I asked why, and this is obvious as well, though. It's high CKs, they've got muscle aches, and again, cardiomyopathy. And then some centres said, well, it's just our standard practice, we just put everybody on it. And then I asked, what do you supplement with? So that was a varied answer there. So the most common one was Protifar, which is the Nutricia protein powder. We've got skim milk, we use Renapro. ProSource is a liquid hydrolyzed protein source. Some people do food. The other was a hemp milk that someone said that somebody was on, and obviously then there's some fat there as well. And I asked, because if you are supplementing with protein and fat, you can't just add that on top of the carbohydrate that you'll be having as well. So I asked people, if you are supplementing, would you take out some of the carbohydrate? And a few centres said yes, some said sometimes, depending on their weight. Some centres said, yes, for every gram of protein we put in, we take a gram of carbohydrate out and do it in a stepwise fashion there. And do we see any improvements? So the hospitals that have done this, have you actually seen anything? A lot of responses were, it's too early to see, we haven't seen any improvement, or those that had, they said they decreased the CKs, they'd improved their exercise tolerance, and it improved the cardiomyopathy. So the next step for us is to, if anyone's interested in, we want to formulate a working group on this to look at in more detail, because when I sent out this survey, I didn't want people to have to go through every patient and work out how much protein and fat, because I know you probably wouldn't reply because it's quite a lengthy piece of work to do. But it would be as a service evaluation, and we'd have to go through each patient, and what we'd like to see is actually how much per kilo people are supplementing with protein or fat there. So if anyone's interested in working with me on that, then please let me know. But when you do a talk like this, you then think, oh, I'll just have a little look and see what else I can find. And so then I discover there's a whole lot of unanswered questions out there. So the four I just want to briefly talk about is, if we are going to supplement with protein, what kind of protein should we supplement? Does it matter what the amino acids are? How much should we supplement? And then what are we going to look at to see if there's any improvement there? So the American guidelines say that we should use whey protein, but when you look at some diabetic studies, that whey actually causes an insulin response. So in GSD, obviously, you don't want to spike in insulin, which will then bring your blood sugars down. So maybe whey isn't the best one to use. And then I looked at the amino acids. So this, again, all these things are from bodybuilding publications where they've looked at how I can get as much muscle deposition as possible. And so this is one that the ISP is just soy protein, whey protein, and casein. But in essence, what this is saying is that if you give leucine and glutamine, the leucine activates a pathway for protein synthesis, and the glutamine can start the process of growth hormone. So those are two of the amino acids that maybe we should be in the protein supplements there. I then also looked at whether it should be essential amino acids, non-essential amino acids, and again, what a lot of the papers are saying that if you're using, you don't actually need non-essential amino acids, you could just do it with essential amino acids. So then you're not going to see this very clearly, but then I thought I'd have a little look at seeing our protein sources that we use. So I wanted 20 grams of protein, and I chose Nutrini as a kind of basis, because obviously that I thought would be a complete profile. They've looked at the amino acids and they probably think they're in the right proportion. So that's the blue one. And then I looked at Renapro powder, so I wanted 20 grams of protein from Renapro. And then a new one that we've used is Renapro Shot, which is a liquid 20-gram protein supplement. And then I looked at Protifar and 20 grams of Protifar. So in essence, the blue one is the Nutrini. There is a lot of difference, and more worrying from our point of view is that we were using Renapro Shot, but because it's a liquid, and I'm sure it's got something to do with that, in that they can't put all the amino acids into it, it's deficient, for example, it's very low in leucine, it's got no tryptophan in it. The Renapro powder is quite good. Protifar is, there's quite a lot of it, but is there one that we could, is there a protein that we could devise that would be maybe a casein-based one and a certain amino acids that would be better for protein deposition there? And then I thought, well, let's have a little look. So these are the protein supplements, but they're varied. So the Protifar and Renapro are milk-based. The Renapro Shot is actually collagen peptide, so it's kind of hydrolyzed. And the Prosor is amino acids. And then you can look at, it never ends, then you can start looking at hydrolyzed versus non-hydrolyzed. And then the hydrolyzed, yes, you get faster absorption, but then you also get insulin there. So you probably don't want a hydrolyzed one. So it's quite difficult to come up with a protein that would be an all-encompassing, but it would be probably a casein, high leucine, glutamine, non-hydrolyzed protein there. So Vitaflow if you want to make one. So then the next step is, like, how much do we supplement? So the American guidelines say 25% of your energy from protein, 3 grams per kilo. So if you've got a 40-kilo child, you're looking at about 120 grams of protein. That's a lot of protein to take. Dr. Weinstein says you just keep adding it until the prealbumin, which is what he uses as his marker, becomes in the normal range. So as a general rule, what we do is that as the children get older, it's very hard to quantify what their protein intake from their diet is, because it varies and recall, and we can't actually calculate accurately what they're taking from their diet. So we actually only calculate their prescribed protein. So that would be things from their Renapro or Protofol there, and we try and get that between 1 and 1.5 grams per kilo, and then we obviously encourage a high protein diet on top of that. And that's what we've been doing for the last few years. So in the States, what they have got on their guidelines is, so again, this is the dietitian's information, is that you to have between 3 and 4 grams of protein. And I just don't think that people actually can do that. They do suggest a load of high protein foods that give details on what you could do, but also the milks that you can use again. But 4 grams of protein is a huge amount to be consuming. So we do this, but what are we actually going to look? Does it really do anything? So this is our, along the bottom is years, and this is CK up the side. So this shows our CKs, and then the arrows are when we introduce protein, and we introduce protein, but we obviously reduce the carbohydrate alongside that. And then we have seen a fall in their CK values. It does yo-yo, it's not perfect. You do see it go back up again as soon as they don't have the protein or they increase the carbohydrate. But in theory, that's all we did, and we've got a drop in CK. But is that the best marker? So we also looked at our going back a number of years. So we've been doing this for about 5 years, and this is our median CKs. And so this is from 2014 onwards. The median levels are less than 1,000. So that's generally, again, what we're doing is increasing the protein. So it's suggestive that it could be improving things. But the area they're looking at now, the medics are looking at, is prealbumin, looking at is that a marker of protein synthesis. It's got a half-life of 2 to 3 days, and obviously these things here would affect the level. Not many places can analyse it, so I think Birmingham and ourselves are looking at that at the moment. But as I mentioned before, Dr. Weinstein doesn't often give his data, but it just so happened, actually, this is a paper that was written to show the efficacy of glyphosate, and actually he did document some results there. Obviously, he wasn't highlighting this, but this is what he was in the paper. And so his levels of prealbumin was 15 to 15.8. Now, the normal range is actually 20 to 50 in males or 10 to 40. So these aren't great levels. So, you know, although he's saying we just increase the protein until we're in that your labs are in the right range. And we've got 17.4 when we looked at ours. So, yes, I think we could all do better, but how we get that increase there. But if this is on the supposedly 3 to 4 grams of protein a day, it's obviously, you know, I'm not really sure people are actually doing that. So, as I said, if anyone's interested in looking at this in a little bit more detail, to let us know. So that's the medical and dietetic update now, and then we're going to just, Abby's going to talk about our obesity and what we're doing about that in GSD.
great. Thank you, Jo. So we're going to look just a little bit about growth, the big issue in GSD. So children, when they come to us with they're diagnosed with GSD, often present with sort of short stature. They have very small, slim arms and legs, and a very distended abdomen because of the liver. Dr. Mundy describes them as lemons on sticks, which is a little bit harsh, but it's actually fairly good interpretation of what they look like. So once they start to have treatment, their growth improves and things improve in terms of that, but they also then have a propensity to becoming overweight. So it's a bit of a tightrope between the overtreatment and the undertreatment in GSD. So if you give too much glucose, you risk obesity, fluctuations in blood sugar and insulin sensitivity. But then if you don't give enough glucose, you risk hypoglycemia, growth faltering, high plasma lactates, high triglycerides and high ketones. So you're sort of treading the gap between those two. So if you think about nationally, about 28% of children are overweight or obese. When we looked at the GSD population, the reports are that some GSD1 patients, between 71 and 99% are obese or overweight, and the GSD3s, between 60 and 83% are overweight. So it's obviously a massive problem in terms of the GSD population. Okay, so why do patients become overweight? I guess the first thing is that the treatment is food, essentially. So you're giving them carbohydrates. So obviously they are going to be at risk of getting overweight because of too much calories. So this is just a plan for a 10-year-old female with GSD. So she has an overnight feed, which is stripped back to just carbohydrate already to minimise the calories from that. So at 7 o'clock, she stops her overnight feed, and then at 7:30, she'll have a breakfast, and then she'll have 50 grams of cornstarch, which she takes with milk. Then at lunchtime, she has school dinners. She'll have 50 grams of cornstarch with that. Again, that's mixed with milk. Then at evening meal, 25 grams of cornstarch with milk again, and then at 8 o'clock, she starts her overnight feed. So just looking at the calorie burden of this, her starch alone gives her 478 calories, and the overnight feed gives her 365 calories. So if her estimated requirements are 1,940, we're actually giving her 43% of her intake on top of what she could be eating as sort of a prescribed calories, if you like. So we're already giving her almost 50% of what she needs, and then she can be eating and drinking on top. Some children eat very well, some children don't eat so well, but we'll talk more about that in a minute. So obviously they are at risk of becoming overweight just because their treatment contains a lot of calories. Okay, so this is the data from a 2017 audit from the Evelina. So we looked at 52 patients. There were 13 with GSD1, 10 with GSD3, 12 with GSD6, and 17 with GSD9. The age range was between 2 and 15 years with a median of 8.5, and 65% of the patients were male. So this just shows that the incidence of overweight and obesity was greatest in the GSD1s compared to the 3s and 6s. This was comparing the data from 2013 to 2017, and it just shows that the incidence of obesity did actually come down quite significantly. So the GSD1s came from 89 to 69%, 3s from 80 to 60%, and the 6 and 9s from 42% were overweight to, in 2017, only 28%. So it is quite a significant improvement. And the bottom graph just shows that they were actually still growing. So they weren't being undertreated and risking their growth faltering. They were still gaining in height as well. So just a little bit about what we've been doing to achieve that. Okay, so in the last 5 years at the Evelina, we've been trying to avoid excessive energy intake while maintaining metabolic stability and growth. So you want to sort of tread that line in between undertreating and overtreating. And we've done this by changing clinical practice and limiting the administered carbohydrate. So we've done a few different strategies to achieve this. So we're going to talk about all these in sequence as we go. So one of them is using height weight for dietary calculations. We're also limiting the administered carbohydrates by regular biochemical profiling. And again, we'll talk more about that in detail. We're educating families more on carbohydrates. So instead of giving them sort of a minimum target for carbohydrate, we'll give them, this is what you should be eating and no more. And then we're also looking at introducing a staged GSD teaching package, sort of similar to the ones we would use in low-protein diets, just to get all the education through in a sequence, really, from diagnosis. So the first thing that we do is we use the height weight for dietary calculations. So we're basically trying to feed the lean muscle mass rather than their fat gain. So we look at height weight, and we sort of call it the Evelina height weight. It's quite a simple, just sort of way to look at. We're basically looking if we assume their height and weight are proportion. So if their height, say for example on this one, was on the 55th centile, we'd estimate their weight if it was also to be on the 55th centile. So just to go through an example of that, this child is 38.6 kilos and his weight is on the 96th centile, which is fairly typical for GSD. His height is on the 55th centile. So we've then worked out that his height weight, so if the weight was on the 55th centile, he'd be 28 kilos. So as you can see, he's about 10 kilos over what we would estimate his weight to be. So if you look at a treatment plan, if we're using his actual weight and a cornstarch dose of 1.5 grams per kilo, which he has 3 times a day, we're looking at energy burden of 665 calories. If then you use the height weight of 28 kilos, the same carbohydrate dose, so 1.5 grams per kilo, given 3 times a day, it's 481 calories. So that actually saves 180 calories a day, which again doesn't seem like a huge amount, but when they're given that day in, day out, it actually does contribute to quite a lot of their energy. So the other thing that we're doing is we see them in clinic every 6 months, and then we'll also do an annual 24-hour profile. So sometimes these are done as inpatient stays, and sometimes they're done at home with home ketone monitoring. And then we look at the profile results, and we do a blood sugar or glucose or lactate or ketones before each feed. So then we'll look at the previous feed and make adjustments to each individual meal in that way. So this is just an example of an overnight feed. So this overnight feed was originally 16% carbohydrate, and he has it 35 mils an hour for 8.5 hours overnight. So this child came into hospital, and we did his overnight feed profile. And just to show you on the results here, the blood ketones all looked fine. They were 0.1 and less than 0.1, but the blood glucose was actually higher than we'd like it to be. So it was 7.3 and 7.5. These were done in the middle of the night, so his overnight feed's running, and we did the blood glucose and ketones at 3 a.m. and 5 a.m., which just suggests that he's actually having a little bit too much carbohydrate. So what we then did is decrease the carbohydrate in his overnight feed. So we cut it down to 12.6% carbohydrate, which then gave him 231 calories. So again, a small saving, but we don't want to overtreat these patients. And if you can do a little bit on every aspect of their diet, then it's actually going to make a big difference. And the other thing just to point out is that the grams per kilo per hour, he started off on 0.14 grams per kilo per hour, whereas if you look at the recommendation, sort of the endogenous glucose production rate, it would be between 0.2 and 0.25. But as you can see, his blood sugars were great on that, so there's no need to treat that much. There's no need to increase it. And then actually what we managed to do is get away with less, so he's now on 0.11 grams per kilo per hour of glucose overnight. So much less than what we would consider his requirements to be, but we only know that he can cope with it because we brought him in and did a profile for it. Okay, so there are lots and lots of reasons why children are becoming overweight. Obviously, what we talked about before is the calorie burden of their treatment, but also there's a lot of other factors. So these children are diagnosed and they're very little. Their growth is often faltering when they first come to us, so quite often the parents will say they're not growing very much, they're much smaller than their peers or cousins or siblings. And then when they start the treatment, they start to improve in height, they start to grow better. And then parents sort of think that actually that more food is better. So we'll give them more food because it'll make things better, they'll grow in height, they'll do better. So that's one of the things that contributes. Also things like they can be really fussy eaters, so they don't actually start feeding that well. So when they do start eating, parents are so happy they're eating, they let them eat whatever they want to. So we quite often see them sort of, having too lots of carbohydrates just because parents are so happy that they're eating. And quite often, so transitioning from feed to food. So if we think that we get these children in when they're very young, they're on feeds, it's got a huge amount of parental anxiety. So they're never quite sure that they're going to give enough. So in that transition of giving feeds that they know they're okay to giving food when it's sort of, was it enough? Did I do the calculation right? They'll tend to give a little bit more just to be on the safe side. And this also, just on the next slide, follows through for an older child as well. So this child is an example. She's about 4 or 5. She's never been a brilliant eater. So we gave her a plan that would be she can have this much carbohydrate, 15 grams from food, or if she doesn't eat, then she gets an equivalent amount of carbohydrate from her feed that she was on previously. So just examples of 15 grams of carbohydrate. This particular child, her main source was spaghetti hoops. She loves spaghetti hoops. So that's roughly about a quarter of a tin. But when Mum came in, she was actually eating much more than that. It would be 6 chips, 45 grams of pasta, or a slice and a half of bread, which is actually quite a really small amount. And again, it just drives that thought, is it enough? Well, I'll just give her a little bit of extra feed because it won't matter. But this happens 4 or 5 times a day. So that extra feed, which is 90 calories, give that 3 times a day, and then you're massively increasing the energy intake, just because that sort of parental anxiety about whether they're getting enough. So doubling up on feed and food. Carbohydrate counting, we're very much about carbohydrate when they first come in and go through the diagnosis and the treatment. And I think we tend to forget about the fat and the protein, and parents don't necessarily consider that when they're looking at the diet strategies. Portion sizes is another big one. They want to give the same portions as their siblings or their peers or their friends, so they give more because they think it's not going to do any harm. And also the lack of exercise, which we'll talk about again just towards the end. So we've got lots and lots of reasons why these children are becoming overweight, and it's just trying to work with the families, with education and strategies to try and improve that. Okay, so one of the things we're doing is educating families on carbohydrate counting and trying to get across the concept that the cornstarch is their starch. So their glycoside or the uncooked cornstarch, whatever they're using, that is their starch, and that's going to be trickled out over a number of hours. Too much starchy foods, things like your bread, pasta and rice, it gets locked in the liver and it can't be accessed. So we need to limit the amount. So it's not necessarily that they're giving more carbohydrate is better, it's actually going to be more detrimental. So they need to strike that balance. So we're looking at the advice of setting a carbohydrate target, not a minimum. And I think it's always, previously the parents have always considered it a minimum, so really to stop at that amount. We're using a lot of pictorial guides for portion sizes and the Carbs and Cals book and also the app, which is really helpful for families just to be able to have a pictorial reference to have a look at. So these are just some of the carbohydrate counting resources. A lot of our families don't speak English as their first language. Some can't read or write, so we do a lot of pictorial guides. This is just one that's been adapted to a particular child. These were her favourite foods, so we just gave them a resource of what the sort of things that they're looking for. And then we can adapt these things for each family as they come in, depending on what their sort of favourite foods are. So we use that quite a lot. The other way is to teach them how to carbohydrate count. So they'll look at the labels, be able to look at the labels per pack, so how much carbohydrate they're going to get from a serving, and then also be able to work it out per 100 grams, so what portion would get their desired amount of carbohydrate. And it can be any amount of carbohydrates. We've got some children on 12 grams, 13 grams, 15, 20. So it will be quite specific to each child, and they'll be able to work out what they need from there. The other thing that we're trying to get across to our families is that carbohydrate foods aren't free. So because they've got no carbohydrate in, we get a lot of families that come in eating a lot of these foods because they don't contain carbohydrate and they can eat as much as they want, but they sort of don't realise that actually there's a high fat content, which is also giving them a lot of calories. A lot of our families have quite a misguided interpretation of nutrition. We've had some families in on the ward recently that couldn't recognise that the sausage rolls on there was really high in fat. They had no idea because they didn't think it contained much carbohydrate, so it was okay. So it's things like that that really make a difference. And also the other thing about bringing them into hospital for a profile, you really get to see what they eat. So if you time your visit to the ward when they're getting lunch, you can get all the food diaries in the world when they're at home, but then when you actually see what's on their plate, it can be quite different. So we had one in recently, and he'd have the pasta, he'd have the spaghetti hoops, he'd have the mashed potato, all together. Whereas you've got this perfect diet history that they report from home. So it's quite a good way of actually seeing what they're actually doing. The other thing we're trying to do is encourage low-fat cooking methods. So again, just basic, normal, healthy eating. So they're not really giving a lot of thought to fat content and things, so we're just trying to look at healthier cooking methods, giving them options, foods to avoid rather than foods that they can have. And some of our guides are just really simple pictorial guides of choose this, don't have that, with a big red cross and a green section, depending on sort of the level of the families there. This is one thing we're also looking at, the GSD sort of plate model. So just to sort of, again, get that concept that it doesn't have to be all carbohydrate. So I saw somebody in clinic a couple of weeks ago, and he admitted that he's covering his plate with the pasta, and then he puts the sauce on top, which again, if you compare it to the sort of ideal plate model, it should be about a quarter of the plate should be his carbohydrate, quarter protein, and the rest in vegetables. And again, that's quite hard, same with the general population, it's quite hard to get across that sort of portion size message. So again, I think that's going to be a bit of a work in progress. The other thing is talking about bulking out foods with carbohydrate, because a lot of the families, they don't want their child to be deprived. They want them to have the same as everybody else. So they want them to have lots of options in a big full plate. It doesn't necessarily just have to be salad. There's loads of foods now in the supermarket shelves that are already made. So things like courgette spaghetti, carrot spaghetti, cauliflower rice, and the slim pasta noodles. An example using the cauliflower rice is that it contains 20 calories and 4 grams of carbohydrate in 100 grams. But if you compare that to regular rice, it's got 132 calories and 30 grams of carbohydrate in a 100-gram portion. So you can get the same bulk, but a lot less calories and carbohydrate. So they can buy it pre-made in the supermarket, or also you can spiralise pretty much anything at home, which they could also do if they were that way inclined. So there's lots and lots of ways to do it, but it tends to just require being a little bit more creative than they perhaps have been so far. So exercise is the last thing. We have a lot of families that don't really do a lot of exercise. That's partly, I think, because they've sort of had this unwell child, they've been in and out of hospital, they don't necessarily want them running around outside, getting cold, getting wet, so they'll try and keep them a little bit away from exercise. But it is an important part of their management. And also, obviously, things like if they get muscle pains, the parents aren't going to make them want to go and do more. So one of the things that we've been trying to do is using pedometers to encourage exercise. And we did this really well with a family last summer. We had these 2 children, they're both quite overweight. We gave them each a pedometer and some score charts of how many steps they did each day. And it worked really well because they were each just trying to outdo the other one. And they increased their steps really quite significantly. Whether it's carried on, I'm not so sure. But again, it's one of those things just to get that extra motivation that they can see a number of what they're doing. So one of the things that we're looking at is looking at perhaps funding for something like a Fitbit. So technology to encourage and monitor that activity levels. So not necessarily going out and doing loads, but just trying to do that little bit more than they did yesterday. The last thing that we're working on is a staged GSD teaching programme. So looking at going through the ages from diagnosis onwards. So diagnosis, doing the prescribed feed plan and the emergency regime. Then moving on to exchanging feeds with solids. Counting carbohydrates, so again, getting that concept in quite early, that it's a target, not a minimum. It's not necessarily better to have more. Then also looking at healthy choices, so they know right from the start about low-fat options, the importance of trying to stick to healthy eating. Incorporating that plate model, and then incorporating exercise as all part of the strategy to try and improve things from where we are. Okay, I'm just going to hand back to Jo. Thank you.
Sorry, I've just got one more slide to show you, just what we've been working on. You can see these on your tables. So that is a GSD book that we've written with alongside VitaFlow. So it is available, and if you it goes through each type of GSD, and it is general advice. It's not too specific, and hopefully answers some of the questions. It can also just do the genetics, etc. there. So these are available from ourselves or VitaFlow. And the only thing that needs to be changed is that the Climb logo has changed now, so we need to have there's another reprint coming in the new year. So following on from that, we then, VitaFlow are in the process of doing a website for GSD. So this is just a few examples of it. So it's really kind of like the book, but as everyone's aware, everyone's just on the internet, and it's much more easy to find something if you've there's a web page on it. So again, it's things like that, but maybe a little bit more details about if you're going on holiday, what your checklist is, and things like that to go with you. So it's not ready yet, but it's something that's going to hopefully happen in the future. And that concludes our talk. I'd just like to say thank you very much to the consultant who's not here, and to my colleagues, the nursing colleagues, the patients, and everyone who replied to my survey. Thank you very much.
Thank you very much for your talk. It was very interesting, and it was really interesting to hear about the update from the AGSD and all the potential projects that are coming up to work on as a group together. I'd like to open the floor to questions, as we have a bit of time before the next talk, if there are any questions. Yes.
Thanks, Joanne. Can I just ask you to give a little bit more on the outcomes of kind of using your soya formula with some of the infants?
So we've only ever used it on one patient. Like I said, it's that standard practice is that we don't use it. So that child is still on a soya-based product now, and he's nearly a year, but he's very severe and we're not changing it at the moment. So, but I think Birmingham, it's their standard practice. I don't know if anyone from Birmingham is here. But when is Anne here? Yes. So I think for your infants, so all the infants are put on it as a standard practice.
Yeah, we do. We put all our infants, the GSD 1As, onto soya. Not that we've seen any difference in their outcome at all. But yeah, theoretically, it's supposed to work better.
Thanks. That was it was a really good talk from both of you. It's really great. Can I just ask you, you haven't really spoken about the use of continuous glucose monitoring and how you might see that as being an important tool or not an important tool in our trying to rationalise the treatment and not over-treat patients.
Yeah. So we have used continuous glucose monitoring, but when we looked at it, there was a difference from our profiles, mainly because there's a time lag. There was 15-minute delay. So I think there is a use for it for trends. But for making dietary changes, we would bring them into hospital for that. But there is a new one out now that you don't have to calibrate and there's no time lag. So we're looking at that. The endocrine team are using that at the moment. So we're hopefully going to do that and then try that as well. Because ideally, if you could do that and also do that at home, then you'd get their normal activity. It doesn't do lactate, but we do look at, obviously, our lactates to make dietary changes. So it's not just glucose alone. But it's very useful, especially if patients say that they feel the child's symptomatic. And if you could try them with a glucose monitor, you could then see, well, actually, if that is the case or if it's just their behaviour.
Anyone else? Oh, okay. Well, thank you both very much. It was a very good talk.